Okay, hello. Thank you all for coming. My name is Dr. Scott Simon as said. I'm a neurosurgeon at ONS specializing in adult and pediatric spinal problems. And today I'm talking about spondylolysis, spondylolisthesis in the adolescent athlete. But first I want to talk about a little biomechanics, a little anatomy. So the spine has three curves, one in the neck, one in the mid-back, one in the low back. It allows the whole spine to work as a spring to offload all the forces applied to it. But ultimately, a lot of the forces are transmitted to the lumbosacral junction, that anchor between the spine and the pelvis. And a lot of those compressive forces are seen by that last disc between L5 and S1. And a lot of the shear forces are seen by the joints, or what's called the facets in the spine at L5 and S1. So there's a lot of stress applied to that level, and it's offloaded a little bit by the ligaments and muscles at that level. But what can happen is you can have problems at that level. And I always sort of have a little trepidation when I'm asked to give this talk because I have to say the words spondylolisthesis and spondylolysis over and over and over. But what are those terms? What does it mean? So spine is a word for spine, listhesis is slip, lysis is another word for fracture. So a spondylolysis is a fracture of the spine, specifically a fracture of what's called the pars, which we'll talk about in a second. And a spondylolisthesis is a slip of the spine, often due to a lysis causing instability. And so it's like a house that's built and not secured to its foundation. So it's built on a hill and it slides down the hill. And so what happens in the spine is you have these stresses that are applied to this area of the spine called the pars interarticularis. Articularis is another word for joint. So pars interarticularis is the bone between two joints. And so in this case at L5, it's the bone between the joints between L4-5 and L5-S1. And a fracture through that level results in an incompetence of the joint. And a bilateral fracture results in disarticulation from the level above to the level below. And at L5, a disarticulation between the spine and the pelvis. Some people talk about congenital pars fractures, but no one's really born with a pars fracture. And we don't see these fractures in non-weight-bearing individuals. They're often in our practice seen in patients who come in with repetitive stress injuries, especially repetitive flexion and extension. And these patients can come in with back pain. And often these are adolescent athletes, often doing one sport throughout the whole year without a lot of cross-training. And they come in with a lot of low back pain, aggravated by hyperextension and relieved with rest. And it doesn't have to be a fracture, it can also be just a stress reaction. Sometimes you have these microfractures in the pars that you can see on CAT scan, but really this shows up as a hot spot on the bone scan. But more specifically, we get MRIs where we see on what's called the stir sequence increased stress within the pedicle and pars of the patient. It could be unilateral, bilateral, and that increased stress often is diagnostic for the potential for a stress reaction or stress fracture. Sometimes the MRI is not good for actually identifying these patients who've had a fracture or not. MRIs are much better for soft tissue. You can potentially see a fracture on an X-ray, and we talk about the Scotty dog, because it looks like a Scotty dog. And if you have a separation at the collar of the Scotty dog, that's indicative of a fracture. But I almost never order an X-ray because it really doesn't change the management. If you have an MRI confirmed stress reaction at the level of your pain, then we do what we usually do. And the presence of the fracture won't change that. The best way to identify a fracture is a CAT scan. But that carries a lot of radiation. Really, again, doesn't change management. And often, I only use a CAT scan for operative cases. So to find out if this patient has an acute fracture, a chronic fracture, you can see if there's a cortical cap on the fracture, which is indicative of a chronic fracture that won't heal. But the issue is these fractures, as I said, can lend to instability, and this instability can result in slip because all of that shear energy is then transmitted to the disc. The disc becomes degenerated, and the slip can occur. And 85% of these occur at the L5-S1 level, and these slips can become symptomatic. Not all slips are symptomatic, and frankly, the majority of these patients who come in with spondylolistheses or slips with a spondylolysis are not symptomatic. But when they are, not only do they sometimes have back pain, but they can have leg pain too, because as the slip occurs, it pinches the nerves. The yellow are the nerves that are exiting the spine in what's called the foramen, or the channels that allow for the nerves to slip out the spine. And when you have a slip, it deforms these channels because the channel is made up of the vertebral body above and the vertebral body below. And when you have a slip, those channels get deformed and narrowed, and that can pinch the nerves as well, causing pain that goes down the legs into the buttocks with tight hamstrings, and sometimes they compensate with this sway back. What are the risks of slippage? Well, the majority of these patients with spondylolysis or fractures of the pars don't slip, but the risk of slippage can be related to gender. Females seem to slip more than males, early age of diagnosis, and lumbosacral kyphosis, or slip angle, which basically is the hill really steep that the spine is sitting on. That will predispose it to further slip. When we see these patients, it's a no-brainer. We just do our typical protocol, and that includes 4 weeks of completely shutting these patients down. It's always the wrong time. They have, meets coming up. They have college applications where the coaches are going to be writing recommendations. The recruiters are coming out. It's always a bad time. But this is what you have to do. In addition, that 4 weeks of shutting down is shutting them down. There's always this sort of back and forth debate with the parents and the kids. Well, what if I play basketball with my friends? What if I do some, stationary bike? No, shut them down, because the last thing you want to do is have them have persistent pain. And they said that, well, they didn't completely rest. Shut them down 4 weeks. If at the end of that period they have no back pain, you bring them back to the office, you bend them back, no back pain, then you advance them to the next stage, which is physical therapy and non-weight-bearing exercise. If they complete that course without pain, again, bend the back, no pain, then they can go on to weight-bearing exercise, sport-specific exercise, and again, 4 weeks. If they have no pain, great, back to graded return to sports. Everything is a graded return. And that results in around 80% of these patients being treated to good effect non-operatively. Bracing is often recommended, but has no bearing on outcome. It often makes everyone feel better, but there's, especially at L5S1, an inability to immobilize that segment with a brace. Early diagnosis of the fracture or unilateral fractures heal better than bilateral fractures, and late diagnosis often doesn't lead to healing. But a healing of the fracture does not translate to an improved outcome. Healing of the fracture sometimes is very difficult in these patients because, as I said, it's hard to immobilize the segments that are fractured, and there's a poor blood supply within the pars. So often healing of the fracture is not the issue. We don't get serial MRIs or X-rays or CAT scans because it doesn't change management. You often have changes within the X-ray, MRI, or CAT scan that don't equate to how the patient's doing. So as I said, these fractures often don't heal. So you can see a persistent fracture on CAT scan, but that doesn't matter. If they're doing well, they can return to sports. You can often see persistent swelling on the MRI. That doesn't matter. As long as they're doing well, that's what you want to see. At the ONS, we've looked at our patients, and so far we have 201 patients identified with a spondylolysis, and we're able to get 93% of those back to their sports. And usually the rest period for spondylolysis patients that we've seen is around 6 weeks. For the stress reaction patients without fracture, it seems to be a little better. 98% were able to return to their sport, and the rest period is 4 weeks. So we see a lot of these patients, and they do very well with non-operative management. But a minority of the patients do have persistent back pain that fails conservative therapy, and these become surgical patients. And why surgery? Because they need to get on with their life, do what they want to do, get back to their sports. Surgery goals are relieve symptoms, prevent slip progression, restore normal spinal balance, restore normal biomechanics. And my sort of favorite operation to do in these patients who have just back pain, no leg pain, just a spondylolysis, bilateral, both sides are fractured, maybe a slight slip, is this direct pars repair. And what I do is I go in there and I remove the scar, the cortical cap of the fracture to make sure you're back to fresh bone graft that, and then immobilize and compress across that fracture with a screw and hook construct, as you see in the right. To be a candidate for that, you really have to fail an extensive period of conservative therapy. You also want to get an injection at the site of the pars fracture just to see if you get a response. So we inject local, you feel great right after the injection. Again, that confirms you probably do well with this procedure. And this procedure, usually I have the kids stay overnight. They usually go home the next day. This is what it looks like in X-ray. And after the CAT scan heals, you can see good healing across the pars. And with robots, which we're going to talk about with Dr. Merrill, this even becomes more safe and more effective. So I can put the screw in with robotic navigation, where we have a preoperative plan based on the preoperative CT that we can bring into the operating room, and under computerized navigation and direct visualization, I put the hardware in, and then I also can identify the extent of the fracture. Because with my naked eye, I only see the surface. I can't see how deep the fracture goes, how wide it is sometimes. So with intraoperative navigation, I can really be very aggressive with making sure I can clean out that fracture completely so I can graft across it and get the best repair I can. For patients who have spondylolistheses or slips with back and leg pain due to nerve compression, really the workhorse is the fusion, where we go in there, we actually decompress all of the nerves directly, and then fuse that segment to stop the movement and stop the pain and and correct the instability. Advance it. There we go. Often we can reduce these slips when they occur, the spondylolisthesis when they occur, and I think reduction of the slip is helpful to reestablish normal alignment, decrease disability. Also, it improves healing because maintaining a big slip angle or fusing in situ with a big slope, leads to increased risk of failure. So what we can do is we can reduce this. Why is that moving? We can reduce the spondylolisthesis and reestablish a more normal alignment of the spine. And people do very well from this. That's it. These are references, and happy to discuss. Thanks so much.